Hi, my name's Prof Griffiths. I'm a consultant upper GI surgeon from the Queen Elizabeth Hospital in Birmingham. It gives me great pleasure to give a talk on conduit complications, anastomotic leaks and conduit necrosis. I have no commercial conflict of interest to declare, but I do work in a high volume centre covering areas of deprivation in Birmingham. I've therefore treated quite a number of leaks in my time. I'm also in the central team for the esophagogastric anastomosis audit, and I've also been involved with the tentacle esophageal project. And we could effectively call this talk 7 fairly random thoughts on anastomotic leaks or conduit necrosis using recent publications. However, I'd like to start with a quote from Ambrose Paré. When the esophagus is sutured, a long period of patient care awaits. I think it's one of my favorite quotes. And although it does apply to when they were suturing the esophagus and the neck due to trauma, it's equally applicable to minimal access and robotic esophagectomy to this day. Some of the publications I'll use to back up my evidence come from either OGA or the Tentacle Project, which you need to be aware were, although looking at similar themes, were different. OGA was prospective, including all patients having an esophagectomy. Tentacle was retrospective, but gave us one of the largest projects looking at patients having an anastomotic leak. And I had 1,509 patients with an anastomotic leak, and therefore was a massive, massive study. I'm not going into great detail, but we used the esophagectomy complications consensus group definitions for anastomotic leak, dividing that into type 1, type 2, and type 3 leaks. And we did the same for conduit necrosis, type 1, type 2, and type 3 conduit necrosis. My first point is that anastomotic leaks and conduit necrosis are probably the same underlying pathologies and just a spectrum of disease. This was one of our first publications from OGA, and it showed that 83% of patients with a conduit necrosis had an associated anastomotic leak. And the ones that didn't were almost certainly going to develop a leak had they not been treated. And therefore, these pathologies are a spectrum of the same issue of poor microvascular tissue perfusion. And we also showed that in the different categories of leaks, that we had by far worse outcome in terms of return to theatre, higher length of stays, higher ICU stays, worsening rates of eating and drinking on discharge, higher readmission, and higher 30 and 90-day mortalities. The second point is that we can predict patient outcome to some extent by using the SEAL score, which was developed by the Tentacle Group. And you can look at their prediction model on the tentaclestudy.com website. So if you have a patient with an anastomotic leak, you can key in variables like ASA, performance status, tumor, age at resection, post-operative day the leak was diagnosed, white count and other factors, and also factors of is the conduit viable, how big the leak is, and whether there's any collections. And this comes up with a leak severity score and the probability of 90-day mortality with a 95 confidence interval. So if you do have a leak and want to use this score, get on their website. My third point is, can we predict patients at risk of anastomotic leak or conduit necrosis? Well, we looked at that using the OGA database, and we couldn't really predict anastomotic leaks using preoperative variables. We could, however, predict patients at risk of conduit necrosis and we did come up with a risk score, which included the variables BMI, ECOG performance status, whether the patient smoked, and whether the patients had a previous MI. And this had a fairly high OROC curve. It wasn't perfect, however. The OROC was 0.775. And if you're interested in that, use the QR code to read up on our paper. My fourth point is we need to think of the conjugate complications as a mediastinal bomb. And this is an explosion taken from the War on Terror. But it allows us to think about this for several reasons. One is that the bomb doesn't just affect the patient, although they are the primary injury in the mediastinal leak. The bomb blast also affects the surgical team and the surgeon, and also the patient's family. And this is an unstudied area in esophageal cancer surgery, but there are other papers on the second victim, being the surgeon, and this is something we want to study in more detail in due course. But thinking about it as a bomb, it also allows us to move to left of leak or left of bang, and I take this from a book called Left of Bang, where Marines in Iraq looked at injuries from IEDs and tried to organize their strategies into avoiding danger and handling damage. And we can do the same in esophageal conduit complications. And if we do the same thing, moving to left of leak in an anastomotic leak would be focusing on prevention. And that would be patient careful selection. It'd be avoiding danger. It'd be optimizing the patients you're going to operate on carefully by avoiding smoking, by getting them rehabbed and fit as possible. During the operation, it's about not damaging the stomach and using a careful no-touch gastric mobilization. And it's about wrapping the omentum and mitigating the risk of a leak if it did happen. Other factors, including pyloric intervention or ICG assessment, are controversial or currently unproven. My sixth point is the treatment of conjugate complications is completely haphazard and non-standardized. We saw from the August study, when we categorized treatment into primary, secondary, or tertiary management, that really the treatments were all over the place and either led to success or failed, or the patient sadly died. Looking at this alluvial flow diagram, you can see that as you move from primary to secondary to tertiary leak management, the success rate is about the same, between 60 to 70%. So if your leak strategy management is failing, don't fail to move to something else, as there's still a likelihood it's going to be successful. What I would say is the ECG definitions don't really help us manage a leak. They're really just for comparing studies and audit standards. How do we treat a leak? Well, it's currently non-standardized. As you know, the complexity is the varying severity of a leak and ischemia, the time of diagnosis, and the fitness and comorbidities of the patient. But it also varies on what is available in each hospital, and that is very different. I would like to quickly mention that the Tentacle study are coming up with guidelines for the investigation and also management of a leak, which will be a valuable addition to the surgical literature and will hopefully allow some degree of standardization. But when we get a middle of the ground leak, a type 2 leak, the management options depend on whether the surgeon believes a sponge is best or a stent. These management options do have some pros and cons. And I think the controversy around stenting is very much the rare but catastrophic risk of the stent migrating into the airway or the major vessels, and therefore the sponge probably does have the most up-to-date evidence, and I think that's what most units are currently using. But my seventh point is VAC stent the answer? It does appear to have some advantages. It controls exudate and improves wound healing, very much like the VAC. The suction effect prevents the stent from migrating, and you can place tubes through the stent to allow either further drainage or nutrition if they don't have a feeding jejunostomy. And in some patients, it's said that you can allow oral intake with the VAC stent in situ, but it still has some disadvantages in that it can't be used close to the cricopharyngeus. It's only available in a 7-centimeter size, and therefore it's not suitable for massive cavities. It's a new technique, and there's only case reports or small series available to show that it does work. What I would say is the company do provide quite an excellent website to learn about this technique in more detail, and you can go to the website there. And they also do provide an expert panel. So if you do email them your leak conundrum, they'll give you some clinical advice on how to manage that leak. I'd like to end there. Thank you for the opportunity to present. It's been a pleasure. And if you have any questions or queries, please feel free to email me. Thank you very much.